Welcome to the Leukemia and Lymphoma Society of Canada's webcast called COVID-19 and What You Need to Know Now. In this presentation, Dr. Donald Vinh will provide a brief overview of SARS-CoV-2 and COVID. He will discuss factors associated with risk of severe disease and will then answer select questions from the audience members. My name is Sonia Muro. I'm the Community Program Coordinator for the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. During the webcast, you will hear only my voice and the speaker's voice. The presentation will last approximately 15 minutes and will be followed by a 30-minute question and answer period. This presentation is also being recorded, so therefore you will be able to listen to it again on our website while following along with the PowerPoint presentation. We will send you an email when the recording is available. At the LLSC, our mission is to cure blood cancers and improve the quality of life for patients and their families. We offer guidance and support to people affected by blood cancer every step of the way. We offer a vast array of services and educational resources to help people affected by blood cancer and their families. One such service is our peer support program. It is a program that matches people affected by blood cancer, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and share similar experiences. It can be a useful program these days to counter the effects of isolation. Next slide. We know the current situation presents many challenges to you and your family. The community engagement managers can help. They are compassionate connectors that can help you cope with your anxiety and isolation during these times. You can reach out to the community engagement managers in your area by calling toll-free 1-833-222-4884. You are not alone. It is my pleasure to introduce our speaker today, Dr. Donald Vinh. Dr. Vinh is an infectious disease specialist and medical microbiologist at the McGill University Health Centre in Quebec, where he is associate professor and directs the immunocompromised host program. He is also a provincially funded clinician scientist at the Research Institute, McGill University Health Centre, where he directs the infectious disease susceptibility program, a translational research program focusing on human genetic susceptibility to infectious diseases. Over to you, Dr. Vinh.
So I'd like to thank everybody from the Leukemia and Lymphoma Society of Canada for inviting me to present to you on COVID. It is undoubtedly a challenging time, and perhaps more so for the audience, given the associated conditions that you are dealing with. My ultimate goal here is to be able to inform you, and perhaps by doing so, we can address some of your concerns. The agenda that I'm going to follow is as follows. I'm going to give an overview of the current coronavirus. I think it's important to make sure that we're all on the same page when we're talking about the microbe that's dominating the news. I'm going to talk about what does it cause and who is at risk for having problems with this coronavirus. We're going to talk about any current treatments and current recommendations, keeping in mind that this is a highly fluid situation. I can tell you that over the last 2 weeks or so, I average about 60 to 70 emails per half day. And there are 3 halves to my day. So you can imagine how the math doesn't work out, but yet it still accumulates. So things are always changing, and we're going to try and give you the latest information, keeping in mind that this is always changing. And of course, at the end, perhaps the most pertinent to you are your questions, or at least some of the select questions, and then I'm going to try and answer them to the best that I can. So why do we need to do this seminar? Because there's a lot of information out there, there's a lot of news, and we need to make sure that we address the facts, because it is undoubtedly a concerning time, and concern can actually present itself as fear. But if you look at the psychology of fear, the major concern that underlies, or the major building block that underlies fear, is a lack of knowledge. And virology is a very complicated field. There is no reasonable expectation to have the general public understand the minutiae of the virus or the diseases it causes or who's at risk. And of course, that's not even considered when the news comes out, which leaves this gaping hole in knowledge for you, the audience. So this lack of knowledge, we're going to need to address. If we don't address it, Lack of knowledge leads to panic, and that is absolutely not what we want. We see evidence of that in other parts of the world. The hoarding of toilet paper is a nice example of the symptom of panic, largely because of a lack of knowledge about what's going on. So what we're going to try to do in this seminar is we're going to try to give you accurate information. Accurate information should empower you. It should give you knowledge, and then that knowledge hopefully translates into safer practices that will alleviate your concerns or your anxiety. So let's start off with basic introduction. Okay, COVID, SARS-CoV, what's going on? So just to give you the context, the virus that's causing a problem right now in not only our community, but in the rest of the world, the name of the virus is called coronavirus. Okay, and it's called coronavirus because in the old days when we used to do electron microscopy, this is a type of special picture of what the virus would look like. You see those little spokes or spikes that are coming out of that little ball, right? So those spikes, to somebody's imagination, look like a crown, and so that would be the name of coronavirus, because it's a virus that looks like it wears a crown, a coronavirus. Coronaviruses are actually not new. They have been with humankind for a very long time. The majority of the time, coronaviruses cause a cold. A cold, remember, is an upper respiratory tract infection that is mild, right? Runny nose, a bit of a sore throat, a bit of a tickle in your throat. You may or may not feel well, and you usually recover in a few days without even hearing about it. In fact, in the past, people would go with those types of symptoms to the clinic and they would say, it's viral, and they wouldn't even test you, okay? But we've certainly come a long way since then. Coronaviruses, actually, one of the major reservoirs for coronaviruses are bats. Bats can harbor coronaviruses in their system, and you can imagine that one bat doesn't actually just harbor one coronavirus, it harbors a whole bunch. And inside the bat, you can have mix and matching of different strains of coronaviruses. For the most part, when you get mixing and matching, it is actually bad for the virus, and it leads to a weaker virus that cannot replicate. But every once in a while, you will have a viral strain that comes out that's a little bit stronger than the components of the original strains that recombined. And we know that happened in the original outbreak of SARS back in around 2002. And then in a subsequent coronavirus outbreak called MERS at about 10 years later in 2012. So now about 8 to 10 years later, we are dealing with this coronavirus. The species of the coronavirus that's causing the current problem is called SARS-CoV-2. So the family of viruses is called coronavirus, but the specific species is SARS-CoV-2. It stands for Severe Acute Respiratory Syndrome Coronavirus 2, SARS-CoV-2. And the disease that it causes is called COVID-19. Okay, so those are some basic terminologies. So when we talk about the virus, it's SARS-CoV-2. When we talk about the disease, it's COVID-19, or sometimes I'll just refer to it as COVID. Now, how is this virus transmitted? So we have to go back to basic principles, which is that coronavirus is a respiratory virus, like other viruses that cause a cold, or the virus that causes flu, the influenza virus. So these viruses are transmitted through the respiratory tract. What that means is when somebody talks or coughs or sneezes or does any sort of that activity, there are particles that come out of the airway, mostly out of the mouth, also sometimes out of the nose, and those particles are of different sizes. Now, we don't need to go through the physics of those particles, but just to let you know that depending on the size, that determines how far that particle can travel when it comes out of the mouth and how likely it is to remain in the air or to sink down to the ground, for example. So without getting into the details, the two major particles I'm going to refer to are called droplets and aerosols. Aerosols are very, very, very small particles that can travel long distances, that can remain aloft in the air for long periods of time, and that can be traveled by or transported by wind currents. Droplets are larger, and they tend to fall about a meter or so away from somebody's mouth. obviously we've all been around people who talk a little bit too much and they spit a little too much and it goes a little bit farther. So 1 meter is at like an average. Some people are what we call super spreaders, so it can go a little bit farther, about 1.5 meters. And so the reason we're talking about this is because it talks about what we can do to mitigate the risks. In the recent past, there was some concern that coronavirus was transmitted by aerosols. And part of that was a hypothesis because of the fact that there were an increasing number of people at a very high rate. And so when historically in epidemiological studies, so in studies of sick people, when you see an extremely high rate of infection over large distances, the hypothesis is that it is aerosol transmitted, like chickenpox virus or like tuberculosis. And that was the major concern at the beginning of the epidemic, which became a pandemic, and that there was an aerosol transmission. But in fact, coronaviruses have never been primarily aerosol transmitted, and we are recognizing more and more that aerosol transmission is not the regular route of transmission for coronaviruses, including SARS-CoV-2. However, droplets are important, and so because droplets are important, this underlies the reason why we highly recommend that people stay at least 2 meters away from other people, more than 6 feet. You need to emphasize that because that is the major mode of transmission, which is the droplets. Now, of course, droplets are not the only way. Most people think that droplets are the only way, but in fact, a lot of people tend to cough, sneeze, or even talk into their hands, or maybe lick their fingers when they try to manipulate things. And so what happens in those situations is that you have these respiratory droplets that go onto your hand. And then the hand can go onto other things, right? Humans are beasts that are very manual. We like to use our hands for a lot of things. And so when we touch something, we risk transmitting a germ onto that inanimate object if they have been contaminated. That's not specific to SARS-CoV-2. This is not specific to the COVID pandemic. This is unusual when you have germs in your mouth and you transmit them to your hands. Those hands can then transmit to other people, either through direct contact or through indirect contact, which means inanimate objects. So we talked about droplet. That's a very important route of transmission, but direct contact, in other words, somebody's contaminated hands can touch you and then transmit it that way, or through an indirect contact, they touch an inanimate object, which then you touch. So the other thing we want to make sure we talk about is a distinction between infection and disease. An infection is when the virus, in this case the virus, enters your body and it multiplies. That is an infection. You may or may not develop signs and symptoms of that infection. If you do, that's a disease, but you may not necessarily develop a disease. You may not develop signs and symptoms. You may be asymptomatic. Whether or not you develop disease, that's one thing. But the other thing you have to keep in mind is that when you become infected with the virus and the virus has entered your body and it's multiplying, it can then be shed. It can then be shed, in this case, through your respiratory secretions, and then you can spread it to somebody else, and that's transmission. So when you get an infection, there are several outcomes possible. One of them is developing disease, and the other one is, are you able to transmit the infection to other people? A disease is, as I said before, is when you actually develop signs and symptoms of the infection. Now you have to keep in mind that this is actually not a black and white concept, that it's not yes or no or one or the other. It's actually a continuum or a spectrum. On the one hand, you have people who have no symptoms or minimal symptoms. They're often called asymptomatic, but sometimes they may have only mild symptoms that doesn't even register for them as being a symptom, requiring informing anyone or seeking medical attention. Then sometimes you have people who have few symptoms, or what we call posse symptoms. You have people who actually develop the true symptoms, and then you have respiratory failure and multi-organ failure, the severe symptoms, okay? So it is a continuum, and that's been one of the issues that's plagued our control of this process, because we know that people who have symptoms can transmit the virus to others, but we're seeing evidence to suggest that people who don't have any clear major symptoms are still able to transmit. So let's talk about them. What are the symptoms that we should be watching out for? This is a figure that I've borrowed that was developed based on the World Health Organization and CDC summaries, which breaks down COVID-19, the disease caused by SARS-CoV-2, and how it's different from flu, which is caused by a different virus, the influenza virus, or how it's different from a cold, which is caused by a whole range of viruses. And so I would ask you to concentrate on the greens, or the ones that have the triple check marks, and just so that you can see what are the major symptoms. For COVID, it's fever, dry cough, and breathlessness or shortness of breath. Of course, you can see that there's a lot of overlap with the other syndromes that are mentioned. So flu also has fever and dry cough. It's felt that shortness of breath is less common with flu. But again, it does depend. I know they put a big X there, like you don't get breathlessness, but that's not absolutely true. You can, and that's confusing sometimes because we don't know when you see somebody if they really have COVID or flu or something else. And that's why some investigations need to be done. And that's why
Sorry,
specific.
Dr. Vinh, I can't see the slide that you're talking about.
Oh, you don't see it?
No. Maybe
Do you
click
see
on
this slide?
the slide. I can see the basic concepts, and that's pretty much where we're at.
Do you see infection and disease?
Infection and disease, yes. Basic concepts, infection, disease with the minimal, no symptom, few symptoms, and respiratory.
Okay, and then this slide you don't see the picture?
No.
Oh, okay.
Maybe
well, I'm not sure what to do there.
Click in the middle of your presentation.
Sorry?
Click with your mouse in the middle of the presentation. And
Yeah.
might activate it. Maybe move it.
I just did. It didn't do anything?
No.
Okay. Well, you know what?
Oh,
It'll be available on the slides.
It's perfect now. Thank you.
You can see it now?
Yes, thank you.
Okay. So just to go back to what I was saying is that there are no symptoms that are specific to COVID. There are symptoms that are more commonly seen in COVID, such as fever and cough and shortness of breath, but there is a lot of overlap with other respiratory viruses, including flu, that are circulating. And so that's also been a challenge for us physicians when we see patients who have symptoms that can range quite widely, and that's why we need to do special tests to figure out exactly what you have. Are you able to see this slide?
It went back to basic concepts.
Right, perfect, great.
Yeah.
So we just finished talking about symptoms now. The other thing I want to bring into your attention is the severe symptoms. Why is COVID-19 such a major issue is because we are seeing this extreme end, what we call respiratory failure or multi-organ failure. In other words, the people get infected, they develop signs and symptoms of the infection. In other words, they develop disease. They develop the fever and the cough and the shortness of breath. But a subgroup of patients go on to develop the severe symptoms, the respiratory failure or the multi-organ failure. That requires ICU admission, intensive care unit admission, often requires a ventilator and other types of care to try and keep the person alive. And that is the manifestation that has been the most concerning during this pandemic. So I don't want to make it look like, oh my gosh, if I get an infection, I'm heading towards respiratory failure or multi-organ failure. As much as there is a diversity of symptoms, there's also a diversity of people at risk for these symptoms. So there's some people who are likely to have no or minimal symptoms, and there are people who are likely to have the severe symptoms. So who are those people who are at risk? And that's what we're going to try and summarize for you today. Who's at risk? Well, just to go back to the concepts, right? There's a concept of infection and disease. So who's at risk for infection? Everybody. And this is important to emphasize because in the news and the media, you see that there are younger people, children, young adults, middle-aged adults who have this false notion that COVID is not going to affect them. That's not true. everybody can be infected by this virus because it is a new virus. And not everybody necessarily develops disease, but everybody who becomes infected can become a vector of transmission for the virus to other people, including people who are at risk for severe disease. So who are those people who are at risk for severe disease? Okay, well, if we look at the original data that as it was pouring out of China, and I have to tell you that this was a fast integration of science into medicine. It was almost on an hourly basis because the data was just pouring in so quickly. But if you look at the epidemiological data that has come out, it's what you see on the left-hand axis are the age groups and also the sex of male or female, and you see the risk of developing severe disease. And what you can see clearly is that at the age of 60 and onwards, the risk for developing severe disease was very high. In this case, it was 2.7 times higher than if you were in the lower risk group. There are several important points to notice here. First of all, it doesn't mean that young people will never get severe disease. That's not true. There are people in the 10 to 20 age group and in the 40 to 60 age group who still got severe disease. So this notion that young people are invulnerable or impervious to severe disease is not true. They're not statistically more likely to get severe disease, but they can still get severe disease. If you have a 1% chance of getting severe disease and you are that one person, you don't really care about the 99 other people. You only care about yourself. And so you have to realize that young people, you are at risk for not only getting infection like anybody else, but you still can get severe disease. But the severe disease is particularly frequent as you get older in the age category. As you can see, people at least 80 had a 5 times higher risk of developing severe disease. The other group that was at risk is males. So we saw that male people were at risk for severe disease. So the two key points in this slide is that older age and male were at risk for severe disease. Now, we always joke around about man flu, how males are more complaining or more severe about flu or that kind of stuff. But this actually may be true in this case for COVID. Males may be more at risk for severe disease. So I only use that as a sidebar to say that if your husband is complaining about not feeling well, just cut him some slack. Now, there are other risk factors as well, right? So it's not just older age and male. There are other underlying conditions that have been identified as being important for being at risk for severe COVID. People who have chronic heart disease. So if you've had what's called coronary artery disease, in other words, you've had a heart attack, or if you've had a heart bypass surgery, if you have palpitations or arrhythmias of your heart, these are all chronic heart diseases that are thought to put you at risk for severe COVID. Chronic lung disease, so if you have what's called COPD, chronic obstructive pulmonary disease, or if you have moderate to severe asthma, these are risk factors that if you were to get infection may put you at risk for severe disease. If you have chronic kidney disease, particularly if you are on dialysis, either hemodialysis or peritoneal dialysis, this is also another risk factor that's been identified. And also diabetes. So this is supposed to be a picture of a pancreas, but when you have diabetes, that's because you have problems with insulin. And again, that's another risk factor for having severe disease. But what about the people who constitute this audience? What about the people who have hematological conditions, particularly the malignant ones like leukemias and lymphomas, or they're getting chemotherapies? Unfortunately, we don't have the data yet. We don't have the data to know do people who have hematological disorders and hematological malignancies, are they at increased risk for disease, and are they at increased risk for severe disease? That's not clear. We don't have that data. Often you will hear in the news that people who are immunocompromised are at risk for severe disease, but the data that's been published or pre-published does not qualify who is in that immunocompromised group. And of course, in the hematology world, that includes a broad range of conditions, from chronic leukemias to acute leukemias to stem cell transplants to benign hematological disorders. And again, that's where we need to try and parse out if there really is an increased risk for disease and severe disease in these groups. I'm going to turn now briefly to the treatments that are available for COVID. Essentially, there are none. There are no established antiviral therapies for COVID. So let me just go off on a slight tangent. For influenza, for flu, there are medications available, one of them being something called oseltamivir or Tamiflu. That's an example of a drug that specifically targets the virus and prevents the virus from doing its badness and lets people recover. There is no equivalent for SARS-CoV-2. There is currently no drug that specifically targets the virus that has been shown conclusively to kill the virus and to abort the disease process, to make somebody feel better. So let me make sure I understand that there are none, okay? So you may read about, and I've certainly, it's been brought to my attention that people have read about things on social media or the news about garlic or about strong concentrations of alcohol or other types of concoctions. That is not valid. There are no data that certainly I'm aware of where they have shown that that is effective. So just don't be fooled by any of the stuff that you read about online. That doesn't mean that there's no hope, okay? So there are promising agents that are being used or tested during the current pandemic, but the data is not accumulated yet. We don't have all the data about how effective it is or how what we call efficacious it is or how safe it is. The data is not ready for prime time. So it's still too early to know if these agents that are promising are effective. The other thing you'll hear about is, well, why don't I just get a vaccine? There is no vaccine that is currently available that has been shown to be effective. There are vaccine trials, so there are groups that have developed what they think is a vaccine, and they are trying it on humans, but we don't even know if they're safe, much less effective. So those vaccines that we are anticipating, they're not there yet. We don't have, they are not developed or available. So what can we do? It sounds pretty grim, right? I mean, gosh, you're telling me about a virus that can cause respiratory failure and multi-organ failure and in a group of people, and we don't even know who the group of people are who are at risk for severe disease, and we can't really treat it. So what can we do? We can prevent it, right? An ounce of prevention is worth a ton of cure. So if we go back to the modes of transmission, we can actually break this chain very easily. We talked about droplets. So one thing you have to do is you have to emphasize hygiene, respiratory hygiene. In other words, if you are going to cough or sneeze, you need to do so in the crook of your arm. If there are people in your household or in your contact vicinity area, they need to do the same thing. Cover your cough or sneeze. The other thing is the droplets, right? We talked about droplets traveling about 1 to 1.5 meters. So that is the emphasis for the 2-meter distance between you and anybody else. We talked about direct and indirect contact, and that is why hand washing frequently and disinfecting surfaces are important. With all these X's, with all these holes in transmission, you are building basically a fort around yourself to prevent you from getting infected. And with this fort, you are preventing you from transmitting it. And that is going to be the most effective tool to stop this pandemic in its tracks. Will it work? It sounds a bit soft, doesn't it? I mean, most people want to get a medication, a pill or an intravenous one, and maybe that's how we're going to stop things. But will it work? Will this distancing and hand hygiene thing work? Yes, it looks like it. It's worked for other epidemics in the past. Humankind has a history of epidemics and pandemics long before the advent of antimicrobial therapies. And the best way to have aborted those epidemics and pandemics is with hygienic measures. So those are the basic principles, and it looks like it'll work here. It looks like it's worked so far in parts of the world that have been affected by COVID. You may have heard of this concept called the R0 or the R0 in the news. Just to define it for you, that's the estimate of the expected number of cases that can be generated by one case. So in other words, if you have one person who is infected and they are surrounded by a bunch of other people who are not infected, and this is a new microbe like it is with SARS-CoV-2, what is the expected number of secondary cases, or the number of people who can be infected from that first case? That's called the R0. And what we can see in the outbreak or the early phases of the epidemic was that the R value was about 3.8, let's say 4. So every one person spread to 4 other people. And you can see that that can explode into a large number of people. It can lead to an avalanche, essentially, of infected cases. But with the distancing measures and the hygienic measures that I outlined, that R value, that R naught, went down to about 1.25. And then after that, when it was even more rigorously enforced, it went down to 0.32. And that is how we choke off transmission, and that is how we choke off epidemics and pandemics. You can look at, you can actually look at it globally, and you can see that in this curve, there are multiple lines, but there's two different patterns. There's the pattern that's going up diagonally, and there's a pattern that's going along more flat in sort of turquoise blue. And the ones that are going up diagonally, as you can see, those are cases that are increasing quite quickly. The ones that are a little bit flatter are the ones that are going slowly. And the ones that are going slowly are the ones that have implemented these strict measures of distance and hygiene. Whereas, as you can see from the diagonal line, Italy, Spain, Germany is in there, Iran is in there. They were perhaps late or loose in their measures, and you can see what happens to the curves. Let's bring it a little bit closer to home. Let's bring it to Canada. This data is already out of date, and it's only been about 4 days since I prepared this presentation. But what you can see is that all the cases are going up. Some provinces are going up faster than others, and again, it has to do with the preparedness and the implementation of the distance measures and hygienic measures. So this brings us to something that you hear about in the news called flattening the curve. Let's flatten the curve. Let me just explain to you what this means. In purple is the expected curve of the epidemic if no intervention is taken. On the x-axis here, you have the days since your first case, or how much time you are into your epidemic. And on the y-axis, in the vertical axis here, what you see is your daily new cases. In other words, how many new cases do we see per day? And as you can see in your purple, you have a very sharp rise. And we don't actually know the number that it should peak at. The dotted red is your healthcare system capacity. In other words, how able is your healthcare to respond to this increase in number of sick people, to provide them optimal care? What we never want, ever, COVID or no COVID, is we don't want an increase in the number of sick people that exceeds our capacity to be able to care for them. Unfortunately, that's what we're seeing with the COVID pandemic around the world. There are countries where they are not able to, they do not have the resources or the resources in place to care optimally for patients who are infected because there are just too many people who are coming in with disease. So flattening the curve means that we need to bring the peak down to the level that's below or within the healthcare system capacity. Now, how do we do that? Several ways. One, the public. The public are the superheroes here, okay? They don't wear capes, but they're the heroes. They have to know their role, and they have to do their role. And their role is distancing, physical distancing, and hygienic measures, okay? They have to do that, and they have to be adhered to that strictly, because if they can do that, we can decrease the rate of increase, and we can decrease the peak. It also means, by the way, that they have to be reasonable in their measures. Don't do things that are not instructed. Don't buy gloves or masks, because you don't need those masks and gloves. Those masks and gloves need to go to the healthcare workers who are taking care of these sick patients. The other component in this graph that we have to address is the government. And at least in this province of Quebec, I can tell you that the Quebec government has been really at the forefront of rolling out their emergency preparedness plan that is very appropriate for a pandemic. And by the government investing in this, they increase the healthcare system capacity. And of course, what we want to do is bring this peak that intersects with this green line down to this peak. And by doing that, we gain time. And the reason that that's important is because if we have the time to respond to an increase in the number of cases, then we can mobilize our resources appropriately. We can mobilize our healthcare personnel. As many of you know, our healthcare system is already fragile, and we have just enough personnel to be able to care for the needs at hand. But if those needs increase, we need to increase the number of healthcare personnel. We need to reallocate people. We need to retrain people. And don't forget, healthcare personnel can also have their own health problems. So we need to be able to mobilize healthcare personnel. We need to mobilize healthcare material. and equipment. Examples of materials, the appropriate masks and other personal protective equipment. An example of actual equipment would be ventilators, intravenous tubings, this sort of things. The time also gives us a better understanding of what's going on. This epidemic or this pandemic is moving constantly. Every hour I get an email about something new about or some new change about this pandemic. If we have the time to be able to absorb this information, we have the time to think and then implement appropriate measures. Time also buys us the opportunity to develop new therapies, to test new therapies, and to develop vaccines that otherwise are not available. Time is of the essence, and so that is why we are trying to flatten the curve. So, to summarize the key points of this presentation is that SARS-CoV-2, it's a new virus. It causes COVID. There's still much to be learned about what's going on. We need to learn a lot more about the virus. We need to learn who really is at risk for severe disease, and I don't think we should be lumping, elderly people and immunocompromised people necessarily in the same category. We also need to learn about how to treat, how to manage. What are the best measures in the hospital or in the community that can manage the various severity of cases? We don't know this information yet, but we hope to gain that information, and we hope to do that soon. What is clear, however, is that social, or what's now called physical distancing, droplet hygiene, so the coughing into the crook of the arm, the hand washing, the 2-meter distance, these work. They've worked before. They will likely work here as well. I cannot tell you the future, but there's no reason to think it won't work. It will work in prevention, but everyone has to enforce it, even to the people that you love. You need to tell them this is what you need to do. Thank you very much for your time. I really appreciate having your attention.
All right, so it is time for a question and answer period. So at the time of registration, we had asked you for your questions and we received an enormous amount of inquiries. So although we cannot answer all of these questions, we were able to choose approximately 15 questions that we felt would help answer most of the inquiries. Please remember that if you have any questions regarding stress and anxiety, we will be able to answer those in our next webcast called COVID-19, Looking After Your Mental Health and Well-Being, which is scheduled for March 31st at 3 p.m. Eastern Time. If you require any specific resources, we ask that you reach out to our community engagement managers by email at canadainfo@lls.org or by calling toll-free at 1-833-222-4884. So let's get started on some of those questions. If you can,
okay, so
next slide.
Go ahead.
So what if I am sick and waiting for a test or a test result?
So if you have symptoms of COVID, let me just make sure that you understand. Symptoms of COVID tend to be fever and cough. Sometimes you can also have a little bit of diarrhea, okay? But those are usually the mild symptoms. If you have those mild symptoms and you're waiting for a test, you're waiting to be tested, or you've been tested but you're waiting for the result, what do? Stay home. If you know people who are in that same situation but don't have a hematological condition, it's the same thing. Stay home. And when I say stay home, I mean no school, no work, no child care centers, no visitors, nothing. People have to understand that this is not a time for social gatherings and casual visits. No. Stay home. If you have symptoms, stay home.
What if I live at home with a quarantine person? So
let's say you are well, but the person you live with, your household contact, has been told, okay, you need to be on quarantine, okay? In other words, you need to stay home for the next 2 weeks. What do you do in that situation where you're living with somebody else who is in quarantine? As much as possible, you need to be separated from each other within the house. At least 2 meters, but if possible, the quarantine person should remain in a dedicated room with the door closed as much as possible. They unfortunately should be recommended, unfortunately, that they should eat and sleep alone in that dedicated room of the house. If possible, they should use a separate bathroom. And that's because there is some data to suggest that the virus can be found in stool. So that ideally a separate bathroom is good. If you cannot use a second bathroom, which is perhaps not realistic for some people's households, then the bathroom, specifically the toilet and the sinks, need to be disinfected after each use. You really do need to avoid contact with other people in the house. This is not a time to frolic, okay? This is a time to be vigilant, even if it's inside your house. And if that's not possible, that you really can't avoid contact with each other just because of the physical space of your residence, then the person who is quarantined, especially if they have symptoms, they need to wear a mask and keep your 2-meter distance. By the way, the other thing people have asked is it okay for me to open the air or open the window and breathe in fresh air? And you should, because as you know, spring is coming and we want to breathe some fresh air. You are not going to get SARS-CoV-2 from your neighbor down the street. So yes, open your window and let the air circulate.
For patients with any type of blood cancer, if they contract COVID-19, how different would be the outcome from a person who does not have a blood cancer? Is every survivor of a blood cancer considered immunocompromised? What extra caution would I want to take right now if I am immunocompromised?
So these are excellent questions. I think the first one I've touched on in the presentation, which is we do not know people who have blood cancer fall into the category of at risk for severe disease. Intuitively, you would, to err on the side of caution, we would intuitively say yes, because there's never been a situation where somebody who has blood cancer is at less risk than the general population for an infection. However, there is no data to confirm that patients with blood cancers are really at increased risk for infection or increased risk for disease or increased risk for severe disease. So we don't know yet. The second question is every survivor of a blood cancer considered immunocompromised? That's a little bit trickier to answer. It depends on the underlying blood cancer. It depends on the type of therapies that they received. It depends on how they responded to that therapy. So that's a bit hard to understand. I'll give you an example. There are people who've had stem cell transplants and they are, 6 years out from their stem cell transplant with no complications and no relapse. And for all intents and purposes, when you look at some of the blood tests, they look like anybody in the general public. And there are people who've had stem cell transplants and there was no engraftment, or maybe there was a relapse, or there was other complications, maybe graft versus host disease that required immunosuppression. And in those situations, obviously, you can't compare the two types of stem cell transplant. So it's a bit of a hard question to answer as a general category. What extra caution would you want to take right now if you're immunocompromised? Is exactly what I said. Build that fort. 2-meter distance, hand washing, respiratory hygiene. Not just by you, but by the people around you. And you know what? If they can't adhere to those measures, you don't need them in your vicinity right now.
How can you keep safe when you go weekly to a hospital to have your blood checked and usually get a unit of blood? Is the blood supply safe during this pandemic?
So there's a few questions here, right? So how safe is it when you go weekly? This is an important question that I think every patient should have with their physician. There are some follow-ups that are routine follow-ups. In other words, they were scheduled and you're coming for, let's say, a test, a blood test. And the question you can ask your physician is, can this be deferred? I can give you an example. At our hospital, any non-essential visits have been triaged by the physician in different divisions, and any non-essential visits have been rescheduled to a different time. On the other hand, you may be on therapy, or you may have symptoms that do require testing. And again, that's where you have to communicate with your physician and determine how urgent that testing needs to be done. It is very possible you will need to come into the hospital to get those tests done. How safe is the blood supply? I was in communication with HIMA Quebec, which is the Quebec equivalent of Canadian Blood Services, and they have a plan in place to survey or monitor the situation. We don't know yet if it impacts on blood products. However, there is data in China to suggest that there have been no concerns of the transmission of a virus through blood products. The other concern for blood products is the availability of supplies. As you can imagine, when people are on quarantine or isolation, or if they're sick, they are not able to go give blood. And therefore the supply is low, and that's not been a major issue yet in either Quebec or Canada beyond the normal demands. But if we don't get this under control, this pandemic under control, we could encounter those problems.
Should I be attending scheduled pickup appointments early April at a regional cancer center is a 6-month checkup. How are hospitals dealing with blood cancer patients and COVID-19?
So this goes back to my previous answer. You need to communicate with your physician, if your physician hasn't already communicated with you, to determine about the need or the urgency or the of the scheduled visits. I can't answer for how every hospital is dealing with blood cancer patients across the country. There are some major cancer centers and there are some more local ones. At the hospital that I'm in, there are hematologists still doing hematology work. Okay, so I want to make sure people understand that we're not only thinking about COVID. We are fully cognizant of the fact that there are other conditions that people are suffering from currently. My hematology colleagues here at the MUHC are fully aware of that, quite vigilant about it, and we have measures in place to make sure that patients who need testing or treatments get the tests or treatments, and they also have measures in place to defer those that are not urgently needed.
I am currently in a clinical trial. Do you foresee an interruption in treatment for clinical trial patients?
So this is also an important question because I also do research, for our hospital, we have an assessment of that in place, so that people who are on clinical trials, again, they'll discuss with their physician about, how feasible is it to continue to participate in the clinical trials. Some clinical trials require a more intensive testing, for example, with blood tests. Some don't. Some require medications at specific times. Some don't. So again, this is something that depends on the clinical trial, depends on the center, depends on the hematologist. So this is something that should be discussed directly with the hematologist who's conducting the clinical trial at your center, at your hospital.
I am a 1-year survivor and also a healthcare professional. I work in a lab. Any suggestions on anything extra to stay safe?
So it's a bit hard to really answer that question, but because there's so many variables here that it's a bit of a vague, I don't have all the details, but if you are in a work position where your exposure to somebody or samples with COVID or with SARS-CoV-2 is high, you should discuss with your supervisor the ability to be relocated to a different task of lower risk. So I'll give you an example. If you here in this case, you say you work in a lab. If you work in a lab and you work with respiratory samples from COVID patients, that may be a higher risk than if you work in a lab and you are the clerk or the person who orders stationary supplies. So it's a bit hard to answer that. The other measures that I talked about with the physical distancing and the hygiene of the hands or the hygiene of the cough, those should be implemented regardless of whether you're at work or at home or wherever you may be.
My current treatment protocol has me receiving rituximab every 3 months after having completed chemotherapy in October. Should I continue to receive rituximab, or should I stop receiving this treatment so as to have a stronger immune system should I be infected with the coronavirus? If the advice is to stop, can it be restarted at a later date?
So I think there's a few points here that we need to touch on. So as you know, rituximab is what we call a B cell depleting agent. In other words, it's a medication that removes your B cells. Your B cells are, for some conditions, it's the cause of the leukemia or the myeloma or the underlying condition, but you also have good B cells that are targeted by this. You also have good B cells that are targeted by this that prevent or decrease your ability to produce antibodies, which are your immune system's bullets to try to fight off infections. It's difficult to answer this question because, again, you should speak with your hematologist about the need for your rituximab. There are different needs depending on your underlying condition. There are different doses, and so that's something that should be discussed with your hematologist. You should know, however, that let's say you were receiving rituximab once a month, every month for the last 4 or 5 months, as an example, and you decide, okay, well, I'm going to stop my rituximab now so I can get my immune system back to fight this COVID. It's possible that your immune system will take a lot longer than a few weeks to recover, even if you were to stop the rituximab. And so we should be cognizant of the fact that what we call the pharmacokinetics of your medications, in other words, how long the effect of the medication lasts in your body, is not an on and off switch. So even if you were to stop the rituximab now, it doesn't mean that tomorrow your immune system is back and ready for action. And so that's something to consider as well in terms of perhaps alleviating your anxiety about these medications. But you also have to remember that you're getting these medications for a reason, which is to control an underlying hematological condition. And so this should be really discussed with your hematologist. Not only the first question, but the second part about stopping and restarting later. Again, those are dependent on your underlying condition and the stage of your condition, and that should be discussed with your hematologist.
I am in my first year of remission off Gleevec. Am I at any more risk of contracting this virus than a healthy person is?
So this is a great question because I don't know the answer. We don't know the answer of what are the effects of different medications on your risk for COVID or severe COVID. We often think that because you're getting chemotherapy, your immune system must be weaker. And as certainly 10 years ago, that was the rule. But we are seeing now that, in fact, there's some types of medications like chemotherapies and other types of what we call immunosuppressants that are actually seem to be strengthening some parts of the immune system. In fact, in some anecdotal stories that we've been hearing from other parts of the world, when people get to their severe respiratory failure stage, some of those people get medications that are, for all intents and purposes, immunosuppressants, and that actually is what helps them recover. So there's a few key points here. First of all, please don't think that, well, I've got chemotherapy, therefore I must have a weaker immune system and I'm at really, really, really bad risk for getting severe disease. That's probably the most prudent assumption to make. So if it allows you to be safe and stay away from other people and minimize contacts with others who may transmit it to you. But factually, we don't actually know that. And so it shouldn't be an overwhelming source of anxiety. And then more practically, to answer this question, we don't know the effect of Gleevec or other types of molecules, small molecules, and the risk of contracting the virus.
Do toddlers in remission from infantile leukemia have increased risk of complications due to COVID-19?
Again, those are questions that are burning us because we don't have an answer. We don't know if this category of individuals are at increased risk for severe COVID or at increased risk for COVID at all. Maybe they're the other counterparts of what we see in children elsewhere, where they just get the infection, may or may not have some mild symptoms, and then they recuperate. So we don't know that data yet.
The Bloodwise in the UK is recommending that all blood cancer patients stay in isolation for 12 weeks. Does Dr. Vinh recommend that?
I'm going to be honest with you, I don't have a crystal ball. I'm not sure where some of these estimated dates have been taken from. For example, in other parts of the world or in this part of the world, we've been hearing different dates about different things. As we know, things change very quickly. What we do know is that the 2-week recommendation for staying isolated, for example, if you've come back from a high-risk area, or if you've been in contact with somebody who has COVID, or if you have symptoms of respiratory tract infection, that's to determine what happens to the virus inside your body. So what we call not only the incubation time, but also the duration of illness to see if you develop any symptoms. 12 weeks is a bit unfounded in my opinion. I mean, I don't know how we tell somebody to stay in their house for 3 months without any data as during a pandemic that's in constant evolution. So I can't say that I know where that data comes from. What I would strongly suggest is you listen to your local regional health authorities. I don't know what the situation is in the UK, but I can tell you what the situation is in my neck of the woods in Montreal. But it may not be the same thing in Toronto or in the greater Vancouver area. Every province has a director of public health for the province, and every major city also has a public health office or agency for the city. They have the greater pulse of what's going on regionally, and they have an idea what the numbers are and what the trajectories are showing, and it's those numbers and trajectories that will tell us or guide us in terms of our recommendations.
If I am currently in remission with normal blood test readings, am I still at increased risk or considered immunocompromised?
So that's a great question, because it's unanswerable. And the reason it's unanswerable is because we don't have very good tests of what the immune system is. When you're getting blood tests from your hematologist, I can assure you they're looking at the hematological system. They're looking to see, is your bone marrow working properly, and is your underlying condition of, let's say, leukemia or lymphoma coming back, okay? That's what hematologists are looking at. They're not looking at your immune system, primarily because there are not great tests available to assess your immune system. The immune system, unfortunately, it's because I do immunology as well. I can tell you that it's also an evolving field, and every month we hear about different types of tests, or different types of functions, or different types of immune cells, or different types of all sorts of things. But they haven't translated themselves into tests that can be done in the hospital routinely. So we can't really tell somebody's immune status by blood tests. What I would say is you should discuss with your hematologist, what do your blood tests show? And if they show that the parameters that they're looking at are normal, that's reassuring. If you have had no problems with infections, that's also reassuring. Both of those in combination would suggest that based on what can be measured, your immune system looks acceptable, but doesn't mean that you are not immunocompromised, or contrary, if you have abnormal blood tests, you are immunocompromised. That requires a case-by-case evaluation between your hematologist and another expert in immunology.
With the possibility of medication production being disrupted, is availability of rituximab threatened? Is there any indication that other medications for blood cancer will become unavailable?
So, not to my knowledge. I am aware about medications being stockpiled and consequently being at risk for being in short supply in parts of the world, but I am not aware that rituximab or other chemotherapeutic agents fall into that category at this moment.
If a vaccine is developed for this virus, am I suitable to get it because I cannot take live vaccines?
So that is also unanswerable at the moment, because as I mentioned before, there are no vaccines. But let's say there were to be a vaccine that develops. There's two general types of vaccines that are in use in humans. Live vaccines, as this person has alluded to, and inactive vaccines, which can be either heat killed or what we call recombinant or subunit vaccines. Live vaccines is when you take an organism, let's say in this case the SARS-CoV-2 virus, and you've weakened it in a way that it cannot reproduce when it gets injected into your body, or if it does reproduce, it is a very, very weak level, and therefore just enough to cause an immune system reaction that we want, but not enough to make the person sick. Those types of live vaccines are what we call contraindicated, or should not be given to certain types of patients, including those who have weakened immune systems, like transplants, for example. On the other hand, there's also different kinds of vaccines where it's either having the whole germ, but it's been killed or inactivated, and there's different ways that can be done, or it's not the whole germ, but it's a part of the germ that's been isolated, where there are no live organisms anymore. It's just little molecules of the microbe, and those are used for injection, what we call the inactivated vaccines. And inactivated vaccines can be, for the most part, given to essentially almost anybody, regardless of their immune system. There are some specific conditions where we would not give it, most notably if you've had a severe reaction to the vaccine before, including any neurological reactions. But this wouldn't obviously apply to here, because this would be a new vaccine. So to answer your question, if the vaccine that ends up being developed from this is a live vaccine, then you need to discuss this with your hematologist about your underlying condition, and if you fulfill certain conditions of being what we call at risk or immunocompromised, then no, you wouldn't get the vaccine. But if it's an inactivated vaccine, then your immune system is no longer, there's no longer an issue.
Thank you. I do know you have a hard stop at 2:30. If you don't mind.
Well, we can finish this one off.
Yeah, okay. So as a survivor who has had a bone marrow transplant, am I at heightened risk if I contract COVID-19? Are symptoms for post-bone marrow transplant survivors different? Does IVIC treatment help with at all against coronavirus?
So again, we would love to know what happens to people who have bone marrow or stem cell transplants. Are they at risk really? Are they at risk for infection? In other words, they have higher infection rates. They are not as higher among transplant recipients than the general public. We don't know. Are they at increased risk for disease? In other words, having symptoms than the general public? We don't know. Are they at increased risk for severe disease? We don't know. And that I can tell you that irks me, because I don't know how to answer patients and I don't know how to care for patients. But we err on the side of caution and we say, okay, the worst case scenario is I'm going to presume that you are at increased risk for infection and disease and severe disease, and I'm going to absolutely do everything, not that we wouldn't do it anyways, to make sure that that fort of protection is absolutely in place. Is it excessive and unnecessary? Well, only time will tell. But I think we want to be overly prudent and safe than underly prudent and dangerous. To go to your last question, does IVIG treatment help? It doesn't. I mean, there are some anecdotal reports that it may, but to be honest with you, we're not sure yet. Because IVIG, as you know, is pooled immunoglobulins from thousands of donors that have been screened to be healthy. This is a new virus, and so presumably those donors have not been infected with this virus before. Therefore, they don't have, or in theory, they shouldn't have any, detectable antibodies to this virus, because it's a new virus and they're otherwise well. And so it's not intuitive that IVIG or sub-QIG would have any immunoglobulins to this new virus. Perhaps in time, we'll be able to see that. And in fact, that's actually being pursued as one type of treatment in for example, in China, they're harvesting immunoglobulins from people who have recovered and trying to see if those immunoglobulins can be used to treat people who have disease. But to answer your question, we do not know, and we do not think that IVIG, that the current lots of IVIG available will have any meaningful antibodies against this coronavirus.
I'm staying isolated in my house. How dangerous is incoming mail as surfaces that might contain COVID-19 contamination? I have family members who are out in the public and can't always social distance. How do I stay safe?
So we don't think that mail is a major mode of transmission. I don't know where you live, but where I live, I don't even get mail regularly. So it probably stays in the mail factory for a few days before it comes to you. I can't speak for the delivery person, but certainly around my neck of the woods, you see the delivery person, the mailman or mailwoman wearing gloves. So it looks like Canada Post is certainly vigilant about that, probably more protecting themselves than the customers. And if you have family members who are out in public and can't always social distance, how do I stay safe? If they have to go out in the public and they have to mingle with people, and then they come back home, then in the home, within your home, you have to implement that fort of three measures, right? Of you distancing from your family member, the hand hygiene, the cough hygiene.
So thank you very much, Dr. Vinh, for being here today. We really appreciate you taking the time to share your expertise with us on such an important and such a big topic. So I'd like to remind everyone to not hesitate to contact the LLSC if you need more information or support. You can reach us by email at canadainfo@lls.org, or you can call toll free at 1-833-222-4884. Also, make sure to check out our website regularly to watch all past webcasts and to watch for future dates of our upcoming webcasts. For example, our COVID-19 Look After Your Mental Health and Well-Being, which is scheduled for March 31st at 3 p.m. Eastern Time. I'd like to remind everyone that a short survey will be sent to all participants after this webcast, and we would greatly appreciate you taking a moment to fill it in as it helps us to offer you the most valuable information in the near future. Thank you once again, Dr. Vinh. I appreciate you taking the time today.
Thank you, everyone. I appreciate it. I hope you got something out of it.
Thank you, everyone. Have a wonderful day and stay safe, everyone.
Stay safe.